The holidays have begun. Winter is here, and so are the respiratory viruses. Welcome to the Urgent Care Association Solution on Demand webinar brought to you by HealthTrack RX. Today we'll be discussing some interesting patient cases and the role of multiplex rapid PCR in optimizing clinical decision-making in the urgent care center during these winter months. Respiratory tract infections can be caused by viruses, bacteria, and they're more common during these winter months and can present with similar symptoms that can cause clinical confusion and make patients really difficult to diagnose and treat. I'm your moderator, Ben Favre. To work through these cases today, we're joined by two experts in molecular infectious disease diagnostics in the urgent care setting. First, we have Dr. Janie French, who is the medical science liaison at HealthTracks and a clinical microbiologist. And we also have Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville Health, most importantly, and he's also has a very important job as Chief Medical Officer at HealthTrack RX. Dr. Goldberg, as we jump into things, I'm interested to understand from a clinician's viewpoint, what do you focus on in dealing with the challenging patients that you see in the urgent care center this time of year?
Well, Ben, I'm excited to discuss these cases and cases that are occurring at this time. As an urgent care clinician, I found it helpful to apply principles of evidence-based practice, case by case by case, so that drives consistent operating by the clinician. That said, each case still has to be considered individually, and we'll show how that's so important on the cases we discussed today.
Very good. Thank you. Let's move to our next patient. So this patient is a 56-year-old that presents with cough, sore throat, fatigue, and a runny nose. Symptoms 1 day prior, requesting antibiotics. The patient history has type 1 diabetes, prior history of sinus infections, and did not receive a COVID vaccine. High fever, 102, and laboratory point of care test was negative. So Dr. Goldberg, another sick person walking into the clinic, help us make sense of what to do with this patient.
It is a busy office hours, isn't it, Ben?
Yeah, for sure.
A few considerations. Having type 1 diabetes is an important consideration. It's not going to change my approach to this patient unless we're having observations that their diabetes are not in control. They've got diabetic ketoacidosis, they're dehydrated or other. There's not that information in the history to suggest that. This patient gives a complaint of a sore throat but has a normal oropharyngeal exam. So that really doesn't support group A strep. And we'll show later that the clinical pictures of several of these illnesses look very, very similar. So I'm thinking viral versus bacterial. The note that point of care testing was negative is noteworthy. So it's inferred by that the patient was treated for both COVID-19 and group A strep, both of which could cause the symptoms described, but I'm leaning to the possibility of COVID-19 because the oropharyngeal exam was normal. And it's suggested because the patient did not receive a recent COVID vaccination. Unfortunately, COVID-19 in the point of care setting testing can have a false negative rate. So I'm processing all that as we're thinking through what to do with this patient.
Very good. Thank you. Janie, what makes this case challenging from a microbiology diagnostic perspective?
Absolutely. There are things that we're going to want to keep in mind. So age is the strongest risk factor for severe COVID-19 infection. This patient is 56 years old, and while we don't classically consider that to be of older age or senior, actually age over 50 is one of the risk factors for severe infection, and that risk increases substantially for patients over 65. Compared with ages 18 to 29 years old, the risk of death is actually 25 times higher in those patients 50 to 64 years old. And while this patient is not a long-term care facility resident, these residents are at increased risk. So we want to be keeping in mind, what are their living conditions like? Because if they are in a long-term care facility, these residents, although only 1% or less of the US population, actually have accounted for 35% of all COVID deaths. So we want to understand what sort of conditions they're living in. Is long-term care a risk factor for them? Fortunately, in this case, it doesn't seem to be. We also want to be thinking about other risk factors, like Dr. Goldberg said, diabetes, obesity, chronic lung diseases, chronic liver diseases, and heart conditions are all risk factors for severe COVID infection. We also want to be thinking about COVID-19 circulation patterns for reasons that we talked about in our first case. Rapid antigen tests are going to have a stronger positive predictive value when circulation in the community is high. And in the US, peak circulation of COVID-19 has, in the past few years, occurred primarily in mid to late July up through August, and then a second peak annually sometime in the December to January weeks. So while these patterns may change as COVID continues to settle into a more regular pattern, this is what we've primarily seen. So it's likely that during these periods of time, the rapid antigen test for COVID will have better positive predictive values. And we want to keep that in mind when we consider our diagnostic techniques available, because rapid antigen tests are accessible. They're going to get patients answers quickly. A PCR test or other nucleic acid amplification test is often going to offer better sensitivity and specificity than a rapid antigen test. So PCR with rapid results is particularly valuable for infections such as influenza and COVID-19, where diagnosis of infection early, within 2 days specifically for flu, means that antiviral treatment is going to be most effective if clinically indicated for that patient.
Excellent. Thank you, Janie. Walk us through some of the clinical confusion that can happen with these patients, please.
Absolutely. When we opened this webinar today, I mentioned that, there's a lot of symptom overlap between common respiratory infections. And sometimes it may seem that it's possible to clinically differentiate common respiratory infections like COVID and influenza. But as you'll see in this table, many of the symptoms overlap between these common respiratory viruses. Really, the only unique symptom to COVID is going to be that loss of taste or smell, which is fairly common during COVID infection, but not as often seen in influenza. In the absence of this symptom, though, you're not necessarily going to be able to differentiate between whether a patient has influenza virus infection or COVID-19. So diagnostic tests are going to be really valuable there.
Excellent. Dr. Goldberg, you have that clinical confusion between flu and COVID here. You also have that opportunity to either treat or not treat because this patient is early in the symptoms. Walk us through how you're going to assess and what you're going to do for this patient who wants that antibiotic.
Then, if we're confident that we're not going to lose this patient to follow-up, if we're confident that they're going to be able to get excellent follow-up care in a congregate living setting, if we're confident that that setting is not going to put them at higher risk, and their chronic condition is stable enough that it's not a separate factor, then what I think we've got is a good setup for outpatient care. And one other factor is that the patient came to us within a day of the onset of symptoms. So what that tells me is if I'm thinking about an anti-infective, either for COVID or strep or other, and the patient's stable, I can wait 24 hours to get that definitive result to then engage them and get that treatment underway because I'm seeing them early. Other clinicians might want to start something empirically, but that would be what I would be inclined to do. I'm particularly concerned because of the normal oral pharyngeal exam for COVID-19 in this patient. And also there was the note of no recent vaccination because as Dr. French described, this patient is at higher risk for a bad COVID event, and they're also at higher risk for long COVID sequela. For those reasons, and yet confidence that we can wait till a next morning result, I would get definitive testing and engage them on follow-up. I think we'd be covered that way.
Excellent. Very good. Great insights. Thank you both. Let's get to our next audience survey question. Would you consider next day PCR testing for this patient? And while we're waiting for answers to come in, Dr. French, I heard on the radio yesterday that where I live in the New Orleans area of Louisiana is having a 10% positivity for flu, and that's higher than any place in the country. Knowing that PCR is the standard of diagnosis for respiratory viral infections, and some of the stuff you mentioned earlier with the importance of the incidence rate in your area, when would you determine, okay, I want to do that PCR, or there's a lot of flu or COVID or whatever it is circulating the area? When do you make that decision? Or is it so hard, as you mentioned with the clinical confusion, that you should test because you have that opportunity to treat for these patients?
Time of year is going to be important because it may allow for preliminary diagnosis. If the patient presents in the summer months with severe symptoms, it's much more likely to be COVID than it is to be influenza, because that's when we see a COVID peak, but we don't see a corresponding influenza peak. In the winter, it really could be anyone's guess because there's often overlap in circulation of influenza virus, RSV, and COVID-19. These all circulate at similar times of the year. So in that case, testing may be the only way to differentiate. But it's always helpful to stay up to date on what's circulating in your communities using publicly available resources. So that's a good place to start. And then testing is often helpful to diagnose officially.
Excellent. Dr. Goldberg, this patient came in wanting antibiotics. And I know that's always a challenging scenario, right? They say they want antibiotics, but really they want treatment. They want to feel better. They want to get healthier faster. How do the current antivirals come into play in a patient like that, given that the patient is early in their course of therapy? And when do you make that decision to say, okay, yeah, we'll treat with an antiviral? And how do you deal with that patient who's insisting on an antibiotic from a clinician's perspective? Because I know that can be challenging and puts pressure on you.
And we're discussing these cases because they're complicated. And clinicians could have the exact same profile of a client and take slightly different approaches. I shared that for this case, I am most concerned about COVID-19. I feel the patient is likely a candidate for antiviral therapy, and yet I feel I can wait until next morning, given the profile, before I would institute therapy, waiting for that definitive diagnosis. Others might take different approaches. They might want to start the antiviral immediately. They might want to, frankly, start a short course of antibiotic immediately. People could do different things, but it's not easy. It depends on the setting, expectations, clinical practice style, but I've shared what my approach would be.
Excellent. A few wrap-up points. Janie, why don't you walk us through your thoughts on the wrap-up points and read them out to us real quick.
We've mentioned this a few times, but the negative predictive value and the positive predictive value of rapid antigen tests is going to be dependent on community prevalence. Using resources that are publicly available, such as virus circulation patterns published by the CDC. Additionally, Health Tracks does publish positivity reports on their website available to the public. These can be a great starting point for understanding what's circulating right now in the community. And rapid diagnostics in general are going to be valuable in reducing patient anxiety, improving patient outcomes, and preventing the overuse of anti-infectives, as we know that antimicrobial resistance is of increasing concern globally. So we want to be good antibiotic stewards. Last but not least, the rapid clinically actionable PCR can be a technique that allows testing for multiple types of pathogens from a single sample. So in situations or cases like the pharyngitis patient that we just talked about, being able to test for both group A strep and respiratory viruses is not only a tool for identifying streptococcal pharyngitis that needs antibiotic treatment, but it's also a tool for identifying viruses so the patient can understand that an antibiotic might not change their outcome. These are really just different helpful points to keep in mind as you go through respiratory season.
Very good. Dr. Goldberg, one of the takeaways that kind of comes through in these cases today is the importance of speed and the ability to get accurate diagnosis in these patients and be able to make that don't treat decision as soon as possible so they can get healthier faster. What are kind of the things you look at from a clinician standpoint on when do you say, okay, I want to do that rapid PCR because I can now get answers back the next morning? When do you pull that trigger and what makes you comfortable? And when do you say, hey, I'm going to use some diagnostic stewardship here and not do a test versus do the test?
Yeah, Ben, 3 considerations. So in someone that's elderly, they're not going to show the signs and symptoms that necessarily affect how ill they are. So I want to get that diagnosis right, and I want to get it fast. First case. The second would be in someone who I am concerned that I have to start a therapy to impact a sequela, long COVID, bad COVID, group A strep, seeding a valve, or a kidney. I want to get that right, and I want to get it done timely. Now, our cases, folks presented within a day, that was an opportunity. But if they were presenting day 3, day 4, the clock is really ticking quickly. And then finally, what I'll add is you really want to do evidence-based practice, have a method that you're using to evaluate these cases, but then look at each individual scenario and points such as where people are living. Are they going to be lost to follow-up? Are any of their health conditions out of control? And then the epidemiologic considerations that Dr. French highlighted are all important elements for decision-making.
Excellent. Thank you both. Thank you to everybody in the audience for joining us for this Urgent Care Association Solutions on Demand webinar brought to you by HealthTrack RX.